We're going to talk today about centering care around what matters to patients today. And this is very, very, very important to us. We know that older adults are growing in the numbers that we see in the field. We have 46 million adults that are age 65 and older. That's amazing. And by 2060, we expect that number to double. And if you think about the implications on the cost of healthcare and on how we provide care, it's significant. So, Amy, can you tell us about Age Friendly, what it's about, tell us about the framework, and why it's so important to value within healthcare in helping us reduce some of the things that we see with our elderly population?
Well, thank you, Marie, and thank you to the American Hospital Association for their commitment, and this clearly is a value initiative. So the notion of an age-friendly health system is a movement. It's a social movement. It's a way to focus in the care on things that are likely to create the greatest harms. And in every health system, in every setting, there are people who are providing exemplary care. And within those same settings, there are people who are not aware of the best evidence-based care. And we can focus in on the things that will have the greatest benefit to older adults. The framework starts with what matters to the individual. Understanding what matters to that person and focusing care and treatment is a way of engaging and activating people in support of their own health. Then we have medications. And medications are critically important, but not all medications. There are in particular 7 different categories of medications that are most likely to interfere with what matters to an older adult. And they're likely to interfere also with things like mentation, which is delirium in the inpatient setting, things that you're working on very hard, and in the outpatient setting, dementia and depression. And the last is mobility. Now, I'm sure everybody in the room is focused to some degree on falls in the work that they're doing around quality. But unfortunately, falls, oftentimes we will assess for fall risk, put a star over the bed, call them a falling star, and create immobility. And what's the end result of that? We create a greater risk for a fall. So it really is on how do we focus on maintaining or improving function, even for somebody who's bedbound. So these things work together. The medications support mobility and mentation and support what matters. These all work together as a set. And so this is the work that we're going to talk about today.
Thank you, Amy. Do you want to talk just a little bit about the evidence that supports the 4Ms as well? There's so much work that has been done around that.
Sure. This is a very light read. And we actually pulled together the leaders of the major evidence-based programs around care for older adults. Erin Emery-Tiburcio around dementia, around delirium, Mary Tinetti around falls. All of the leading people, Eric Coleman around care transitions. And we reviewed all of the components, all of the elements of care that really support better health outcomes. And in fact, these were the primary ones that they focused on because the evidence is not only strongest, but you are able to see the outcomes soonest. You, the older adult, the payers, all will begin to see the value proposition the soonest.
Thank you. Erin, you work in this every day, live it a little different than I do right now, but you're living it every day. Can you give us some thoughts about what you're hearing in your experience with what matters in Age Friendly?
Absolutely. I think the what matters piece is critical to start with the older adult. And as we're doing that, one of the ways that we are approaching that is to talk to older adults. And we're starting out in the community. One of the ways that we're doing this is having events in the community. We were just last week in a African American church on the west side of Chicago, starting a conversation about what matters to you as you age. And as we're having this conversation, there was a woman who raised her hand and said, well, so what's really important to me is being independent. And she said, I think that's probably the case for lots of folks. But for me, I had been in the hospital 2 years ago. I was in the hospital 9 times. I was on 17 medications, and nobody would listen to me. And nobody would listen to what I knew was wrong with me. I finally found a doctor who would listen to me. I am down to 3 medications, and I have not been in the hospital in a year. And so part of that event and part of the event that we're doing is going out and having conversations in the community to hear some of these stories, and then giving older adults an opportunity to make their own video telling us what's important to them. And then using these videos of the voices of the older adults themselves to not only get other conversations started with other older adults, but also in our medical school, in our nursing college, and across our health professions education and our interprofessional education to help people to begin to listen to older adults. So the woman whose story I just told you, we have a video of her. If we could play that video.
My name is Bernice Porter. What aging well means to me, I want to be independent. I love being independent. I love to feel good. I love that I have a partnership with my doctor. I like taking advantage of community resources, and I like advocating for myself, and I like talking to seniors about what's available for them and telling seniors how to advocate for themselves with their doctor, in the community, and whatever it is that you're involved in. Be an advocate for yourself. That's what I like. I love getting up, getting out, and being active.
So Bernice, we are now recruiting to be one of our ambassadors. I couldn't have scripted that for her. And so we're very excited to be able to utilize the community. You know, there were some community health worker elements that were described earlier, and this is another version of that to help older adults tell the stories. And one quick aside is that when the pastor stood up, we were talking about these very short videos. We said, you've got 1 minute. And so the pastor stood up and he said, okay, you need to think about what you want to say to your doctor before you say it, and be really concise. And so having the pastor talk to them about how to talk to their doctors was also really important. So we're excited to be able to take these videos and use them across the community and across the health system to help people begin to listen to what matters.
That's a great video. What a wonderful spirit that she has. Amy, we had several pioneer organizations who started this work with us and have been working in this longest. Can you give us maybe some feedback on how that went, and then on some of the great things that came out of the pioneer organizations?
Sure. So one of the things that we found is that doing this work, focusing in on what matters, medication, mentation, mobility, really streamlined the work. And we did this work prototyping with Ascension, Trinity, Providence, St. Joseph, Kaiser Permanente, and Anne Arundel, which is in Maryland. It's a smaller healthcare system, but they have a global budget. So they really are on the far end spectrum of operating in a value-based environment. And Ascension, for example, built the 4 M's into their annual wellness visit. And they've done more than 10,000 to date. And they're seeing significant improvements in all of their quality metrics as a result. The earlier panel was talking about pressure ulcers and falls, and it basically fed into all of their quality measures. Another one, Anne Arundel Medical Center, in addition to their improvements in quality, and by the way, they're the ones that suggested changing from the ubiquitous pink pitcher, which older adults really can't pour, so they weren't drinking and they were getting dehydrated and falling, to the sippy cups, you know, the ubiquitous sip cups. So they actually tracked the time given back to older adults. And they found that in 1 year they were able to give back 10 years to older adults in avoidance of emergency room visits, avoidance of other kinds of healthcare visits, hospitalizations, and so on. And the community was thrilled. But my favorite actually is a person named Randall, who is a volunteer at Anne Arundel Medical Center who works locally on the project. And he said, I used to see people who would walk in, my friends, they would walk into the hospital with an emergency, and they wouldn't walk out. They'd be wheeled out. He said, now they're walking out. That really says it all.
That's fabulous. Erin, sometimes getting buy-in in an organization is difficult. Even though in this age-friendly model, really we're not asking necessarily for new processes and things. We're taking processes and asking people to look at them through those lenses. But talk a little bit about what kind of things you did to get leadership buy-in, to get people interested, and to commit to going age-friendly.
It's an effort of both top-down and bottom-up, trying to engage folks. And I think one of the pieces that I've gotten the most feedback about what people latched onto was the story of an 89-year-old man who went to the emergency room with his wife, and his wife told the ED doc that he had just had a seizure. So per post-ictal protocol, she gave this 89-year-old man an Ativan, which, as Amy mentioned, high-risk medications instantly caused delirium for him. So as he became delirious, then needed to be admitted to the hospital because his delirium was hyperactive. And because they were very concerned about this hyperactive, delirious gentleman falling, they kept him in bed. And as they got him up to go to the bathroom, he fell. So it was interesting that the one thing that was most important to this particular couple, because this gentleman has Alzheimer's disease, is that he not experience a delirium. That was the most important thing to them. And nobody ever asked what was most important to them, because, of course, in the context of dementia, delirium causes permanent decline very often. So nobody asked what matters. He was given a high-risk medication, which caused delirium, and which caused an admission to the hospital. Then he fell, so addressing literally all 4 M's, which turns out the gentleman actually did not have a seizure, he had a TIA. He could have been dismissed from the ED back to home. Instead, he had a hospitalization, he had multiple medical issues, and he had physical therapy post-discharge. And every single person in the health system did exactly what they thought the guidelines were telling them to do. Had they looked at this particular individual through the lens of the 4 M's and had addressed each of those 4 M's, he would have been discharged from the emergency room without all of that. So we can do better and more consistently. Full disclosure, that gentleman's my father and is now in a dementia unit because he couldn't go home at that point. So the idea that we can address what matters to families and have better health care and have better health costs, so we wouldn't have incurred all of those costs as a health system as well. And so if we think about the numerous ways that we are able to decrease the hospitalizations, decreasing length of stay, there are so many opportunities to do that by addressing the 4 M's. And so as we're talking about buy-in and talking about those exact examples, and each time I talk about that with our leadership, with our nursing staff, and every person in the room says, oh, I have a patient just like that. I have 17 patients just like that. Well, we can do better for those 17 patients, and we can do it pretty inexpensively. I'll talk a little bit more about that.
So, Erin, what's next for Rush?
So we have developed protocols on 2 med-surg units, 2 rehab units, and we're getting started in primary care. And so as we are working on figuring out protocols, workflows that work best, getting so part of our challenge with building that ROI was that we didn't have ways of capturing some of our information. So as we're building in Epic and making sure that we have all the tools, one of the issues that came up was our primary care docs, as we're talking about burnout, they hate the annual wellness visit, and they feel like it's a bunch of administrative checkboxes. And so we're doing an overhaul within Epic of how we document those and incorporating the 4 M's very explicitly so that our primary care docs are seeing the clinical utility of doing an annual wellness visit and are able to link that to the care plan. And the folks that we've rolled it out with thus far are saying, oh, well, if this is what I'm doing annually, if this makes sense to me, the 4 M's, that makes sense to me, I can do that. And so our intention now is to roll out then to the rest of our the Rush Hospital, and then as we are building across our health system to our other partner hospitals as well.
That's great. That's exciting work. So thank you so much for your time. Erin, thank you. Amy, thank you so much for participating with us today. We appreciate it.